Good night, Trinidad and Tobago, and welcome to Psychology Live, your regular Monday night show where we try to discuss issues around wellness, around living a better life, a more positive kind of lifestyle, given all the stressors that we face. Tonight we are talking about Alzheimer's, and I will introduce my guests in a few minutes. Let me remind you that we are streaming live on Facebook at facebook.com/OurTV4, and we are on streaming live gisltd.tt/TV-4. You can also get us on Twitter, TV4, #PsychologyLive, and our phone numbers are 675-8747 and 675-8749. So tonight we are talking about, on our calls, of course, the lines will be open probably after the first segment in a few minutes. So I'm very privileged tonight to have three guests, one representing the Alzheimer's Association, one is an occupational therapist who has created a space for our elders, senior citizens, where she keeps them active. And the other, my last guest is a psychologist at UWI, and they will all talk to us about dementia in general and Alzheimer's specifically, since we are an aging population, Trinidad and Tobago, that is. The CSO estimated in 2002 that we had something like 10% of our population over 60 years of age, which qualifies us to be an aging population. In 2010, it was 12%, about 156,000 persons over age 60. And the UN estimates that by 2025, you will have nearly 18% of our population over age 60, raising to 30% by 2050. So we are clearly an aging population, and this topic should be very important for us, given these trends. To my immediate left is Dr. Khatisha Khan, and she is a neuropsychologist at UWI. Dr. Khan specializes in research and assessment of dementia and Alzheimer's disease. She's a lecturer in clinical psychology at UWI Mount Hope, and she's also the president-elect of the Trinidad and Tobago Association of Psychologists. Welcome, Dr. Khan. To her left is Dr. Leslie Garcia, who is an occupational therapist, very active in Trinidad for the past 11 years, advocating for persons of all ages with special needs. She's the founding chair of the Occupational Therapy Association, which is celebrating its 10th anniversary this year. She's also the program director of Hibiscus Place in Petite Valley, which is the first therapeutic adult daycare center for seniors. And she is working with the University of Southern Caribbean in developing a graduate program, a master's in occupational therapy that will soon be offered there, hopefully this year. So welcome.
Thank you for having me.
Dr. Garcia. And my third guest is Mr. Lyndon James, who is the treasurer of the Alzheimer's Association. He's a family man, as he says, accountant, and part-time caregiver for his mom, who has the disease. He also indicated that his grandmother had the disease, and interestingly, because of a lack of knowledge, which has affected many of us, he wasn't aware at the time, or fully aware and cognizant about its effects at that time. So he got involved with the association because of these linkages through a mutual friend and his mother and sister. So welcome.
Thank you.
Lyndon, and my other guests. And so let me start off by talking to Lyndon as the treasurer of the association, Alzheimer's Association,
Yes.
in terms of your engagement and why.
Well, why is because it's affected me personally.
Yeah.
And I saw how it affected my friends.
Mm-hmm.
My grandmother, as you intimated earlier, had the disease.
Yes.
And, we didn't know at that time that she had the disease. My mom she displayed tendencies of having the disease, and it was really through doing research, you know, and looking at her behavior patterns that we decided to check it out, and that's how I got involved with the association. Really, I wanted to find out as much as possible about the disease. I also wanted to check to make sure that I could understand how to treat my mom.
Right.
Right. And it's been an eye-opener. I've learned quite a lot over the time I've been with the association for the past 6 years. Yeah. I've been to a couple of international conferences. I've learned quite a lot about the disease and how it affects not just the person with dementia, but the caregivers themselves.
Right. Excellent. Leslie, don't mind me calling you Leslie. What got you into occupational therapy, first and foremost?
Okay. Well, I was a teacher for 10 years before being an occupational therapist. I was working in Japan, and I was also volunteering at a crisis line for foreigners in Tokyo. And I came across a school for children with special needs in the international community for people who spoke English. And I just became interested in finding out what they offered. And when I went there, I discovered what occupational therapy is from that sort of roundabout way. And I had been a teacher for a long time, and I went into teaching to help people who were disadvantaged. I was an English teacher, and I worked with migrants in the States and people who I thought learning English would give them a better chance of improving their lives. And I discovered that it wasn't as fundamental as I wanted to make a difference. I actually ended up teaching people how to go shopping and how to use their credit cards on vacation in Hawaii, and that was not my intention as wanting to be a teacher. So I discovered occupational therapy as a profession that really works with people who have significant needs, children as well as adults all across the lifespan. And I went into it thinking it was a healthcare profession that would be interesting, and I would have the opportunity to learn. And it was in school that I realized that it was much more than just a clinical practice. It gives me a chance to really advocate for people who have disadvantages because of medical conditions, social conditions, environmental conditions, even legislative conditions. So it gave me an opportunity to work as a clinician, as an advocate, and hopefully one day as a teacher of occupational therapy.
Right, wonderful.
Yeah.
And Hibiscus Place is how long? 4 years?
Hibiscus Place, we are in our 4th year.
Right.
We started in January 2012. And why I started Hibiscus Place was when I came back to Trinidad, I was working mostly with adults in an outpatient setting. I would see the typical occupational therapy patients, people who had fallen and fractured a hip or who had had a stroke. And I realized that once people had finished their therapy with me, they would often go back to nothing.
Yes,
the
home
older
environment,
adults would just go back to a home environment where they weren't active, they were self-isolated. And sometimes they would want to continue occupational therapy just because they had some social interaction.
Right.
And it became kind of a revolving door, which is something that happens when there aren't any services for at-risk older adults who are left alone at home. They're at risk of the falls, the depression, the isolation. And so I thought this would be a more efficient way to provide services that would be preventive. So people would prevent the depression, the risk of falls, and it would automatically provide the socialization with staff that are trained to communicate appropriately with people who have the cognitive and communication challenges. So that's why I started Hibiscus Place.
Wonderful.
And my mom has Alzheimer's, I can
Yes.
disclose, and so I couldn't find an appropriate place for her.
So in both of your cases, it's been very personal.
Yes.
Yes,
Yeah.
yes, which is wonderful. In the sense of the engagement, I mean, I kind of relate too, because I have a mom who's 85 plus, you know, and so it's, you know, it's very, very part of my consciousness.
Yeah.
So Khatisha, tell us more in terms of the definitions, clinical, of dementia and or Alzheimer's.
Well, in terms of a definition, dementia refers to a syndrome, and there are many, many causes of dementia. Alzheimer's disease is one cause of dementia, and it's one of the more prevalent causes. So it's one of the most popular forms of dementia. Often in the Caribbean region, because we have very high rates of unmanaged diabetes and hypertension and high blood pressure.
So some of the risk factors.
Yes, what you find is that many people with dementia may often also have a mixed dementia, which means they have Alzheimer's disease, but they also have a vascular dementia. So that complicates matters because now we have these two factors combining. Where I think a neuropsychologist has a big role to play, but it's still very much a growing role in the Caribbean, is in terms of the diagnosis and the assessment. So I think a gold standard for diagnosis and assessment would involve a neuropsychologist who would assess for different cognitive domains, so those areas that are affected, like memory, language, concentration. So we help to assess all of these and to help rule out if this is somebody who is just worried because they've gone into a room and forgotten why they've stepped into the room. Is this somebody who does have a memory impairment, but it's not so abnormal to be considered a dementia? Or does this person have a range of cognitive impairment that does meet criteria for dementia? But then there are also different kinds of dementia, so we can help differentiate which kind of dementia there is. I think that's an important aspect because different dementias have different prognosis, different treatments, different interventions. It also helps carers and people with dementia understand more about what's going on with themselves.
Right. So the neuropsychologist basically, and part of the reason for the show is to help break down some of the barriers and to help explain to the public the varying types of psychology.
Yes.
And you know, as I referred in our first show, the APA has about 50 plus categories of psychology, right? We won't get into all of them. But the neuropsychologist, as you just said, can help concerned family members or individuals who are concerned about the progression of any kind of disease as to where they fall to make it, to pin it down in a very scientific way, based on assessments, I gather, different kinds of assessments.
So it is rooted in a science and measurement, but it also has very practical implications. So one of the roles that the neuropsychologist can play is in diagnosis and assessment, but beyond that, and where this is important for the actual person, after you've gotten the diagnosis, what next, is it can help assess a person's range of strengths and weaknesses. So what areas are you better at and where are your weaker areas that we'll have to monitor more closely. And that has real life implications. What can they do and what can't they do? Can they still drive? Can they still cook? Can they still hold down a job? So that's helpful in terms of the vocational implications. There are real life implications. They're functioning in their home, so you can help communicate to their caregivers and relatives what they can and can't do and work from there. And also, we can help to monitor the change and progression. So we can see if things have stabilized, if they're getting worse, so we can monitor to have an idea of how we can best help manage the care of the patient.
Right, thank you. As we go to a break, let me just give some basic information. As Khatisha said, Alzheimer's is one of the most common types of dementia, and it makes up something like 50 to 70% of cases. And during one's lifetime, about 10% of people develop the disease at some point in their lives. Some 3% of people between the ages of 65 to 74 have dementia, 19% between 75 and 84, and over 50% or nearly 50% of those over 85 years of age, and this comes from the Alzheimer's Association of USA. We'll take a break and come back and continue the conversation on Alzheimer's. Welcome back to Psychology Live. The topic tonight is Alzheimer's. Let me remind you that you can call in when the lines are open, 675-8747 and 675-8749. My guests are Dr. Katisha Khan to my left from UWI Mount Hope, Dr. Leslie Garcia, who is an occupational therapist and runs Hibiscus Place in Pidi Valley, and Mr. Lyndon James, who is the treasurer and a board member of the Alzheimer's Association. Question, Lyndon, in terms of, as someone who has had Alzheimer's affect his family, what are some of the challenges that you went through or that your family members went through in terms of coping and just building your knowledge about Alzheimer's? If you could share that with us.
Okay. One of the main challenges, it's really about dealing with, the person who has the disease and trying to sort of relate to them in the past to what they are now. One of the things that, as an association, we always tell all the caregivers that we see is that you never argue with someone with Alzheimer's. It's like hitting your head against a brick wall, right? And, many times caregivers, depending on the person who has the disease, who they're dealing with, feel that they could reason also with someone who has the disease. Depending on their stage, and Dr. Katisha will tell you that, depending on their stage, they get to a point where you really can't expect to be reasoning with them. So, thinking that you're dealing with the person in the past as you knew them, and the person that they are now, is one of the major challenges. And then there are several things that come with that. Their independence, legal issues, sometimes financial issues that caregivers, they don't think about, but they affect them as the disease wears on. Things like having accounts, regularized, or getting a power of attorney, those sorts of things. A lot of people don't think about those things. And then, it's almost like when it happens, it's almost too late. Because you can't get a power of attorney with someone who, is proven to have the disease because they're not of sound mind. Right? The banks will not let you touch the money of someone with, and so, your family members might have put aside a large amount of savings or whatever, and you have to deal with them now with their illness, and you can't have access to it. So those are some of the challenges that face persons, and what we try to do in the association is to let caregivers be aware of some of those things that they will face, because it is an eye-opener for many, right? And like I say, depending on your action or inaction, it could be too late. It's
really quite a challenge until you are in the position.
Right.
right? You could read all the theory and so on, and the different stages and so on. But when you're actually in the position and engaging with the person or persons as a caregiver or a child and so on, it's really an eye-opener in terms of the impact that it has on you.
Yeah.
And you having to adjust to suit the other person or the person that is affected. You want to share some thoughts with us, Leslie, in terms of your experiences and the folks that you do therapy with, occupational therapy with at Hibiscus Place? Yeah.
One of the things that you just said is really important. Day centers like Hibiscus Place offer services to the individual, but the impact is really for the individual and the family. So the approach is to support the entire family in the community to allow their elderly family members to continue to live at home. So first we start off with the understanding that most people want to continue to live in their home because that's a more familiar environment, and those hardwired memories and routines in the home are what will support the person, as opposed to being placed in a new environment where they have to relearn new patterns, which may be impossible for some depending on the stage. So the caregivers who are able to have some time away from what Lyndon was describing as the constantly having to adjust and to deal with this person who may not be reasonably perceiving reality. It makes no sense to try to reinforce what reality is. We don't do that because that can lead to what people call difficult behaviors. So difficult behaviors really, not to be harsh, but difficult behaviors come as a result of caregivers not doing the adjusting in the situation because the person with the dementia isn't going to be able to. So that constant having to readjust, that constant having to communicate in a particular way, that is very draining. It's very draining and tiring for family members who may be learning it just on the fly.
Right, on the job.
Just learning it on the job. They may be lucky if they can get to the Alzheimer's Association and get the information in the support weekend on the Saturdays, or if they can look up online or meet with occupational therapists or the neuropsychologists who can give assistance. But if they have some time where they can just understand that it's okay for them to take care of themselves while their family member is being well taken care of somewhere else, that's the best of all worlds. So the caregiver understands they are going through what really should be accepted as a grieving process because they're losing the person that they know. So they have to accept that they have to change, plus they're losing this person and all of the demands of an aging elderly person that is in their care. With or without dementia, that's a challenging thing in Trinidad anyway. So from an occupational therapy point of view, we try to help the family members by providing the service so that they can get respite. Then we also do stress management and communication training so that they understand how to avoid the difficult behaviors through activities. So for instance, a common thing is people may not want to bathe. They may not want to change their clothes. So we help the individuals figure out when to fight the battle, how to choose your battles, and how to go through activities, everyday occupations, in a way that will support the individual doing as much as they can, because we want to have them maintain their skills so that they can engage as long as the changes in the brain will allow. So there's certain things that can be done to facilitate eating. An environment at the different stages, people may be easily distracted, may have perceptual changes. So if you have a table, you may want to remove the clutter so that the focus is on the meal. You may want to have high contrast at the table. Things that are red will stimulate appetite. So we at Hibiscus Place, we have our dining area deliberately and specifically set up so that participants perform well in the occupation of eating, because we know who is easily distracted, so they face a non-distracting environment. We know who needs support physically, so the table and the knives and forks and things are easy for them to continue to work through. We know who needs to be cued. We know whose plate might need to be turned as we go along. And of course, we have a lot of red utensils at our table. So things like that are ways that we help families. And then throughout the day, the activities are designed specifically to use the strengths that Khadija was talking about. We want to continue to allow people to be successful and to experience pleasure through their occupations, because that's the only way you can have a good time, by doing something.
So it's really about trying to ensure a certain quality of life for as long as possible.
Exactly.
In a very, just mindful that this person has a disease like any other disease, and there are certain symptoms, risk factors, and certain treatments to help both the family and the individual concerned.
Right.
One of the questions on the break, Khadija, was whether young people or younger people can get Alzheimer's.
Yeah, and so the answer to that is yes. It's not as common, but young people can get a dementia. There is a familial form of Alzheimer's disease that's associated with a certain gene. So you can get people coming with an Alzheimer's disease at an earlier age, and testing will confirm that. However, there's no need for families to be overly worried that if you do have this gene that you will get Alzheimer's disease. It doesn't work like that. There is no way to predict, but you can help confirm to know that, okay, this is the reason. I remember seeing a 54-year-old man in Trinidad, physically perfectly healthy. So this is a gentleman who didn't look ill in any way, and I think because of that, because he wasn't old and aging, and there was no change to his physical functioning, the changes he was going through, the cognitive changes, weren't detected until they were so severe. So by the time he came to the attention of a doctor, he couldn't tell you what his name was. So I wanted to lead into that, and also the other dementias young people can get would be ones that are associated with other causes. So if you've had stroke, and young people can get strokes, or other secondary causes, so drug use and other conditions can cause a dementia. But for Alzheimer's disease, it tends to be older. But what I did want to mention, Keith, is that, and especially I think in Trinidad and the Caribbean, I think early detection is so key.
Critical.
I think our extended family setting, our culture, we take care of our older ones. So if Granny can no longer make a cup of tea by herself, we tell her, it's okay, I'll do it. If she can't remember her PIN number for her card at the ATM, it's okay, we'll modify. But these sometimes are little signs that we need to be aware of, and to realize, oh, wait a minute, these few things added up together, this is a change, and maybe I need to go see a doctor about this. So some of the changes are related to normal aging, but some things I think we need to be a little more aware of, and we spread the knowledge and awareness. When you do notice the changes, and it's not just about memory, you can also have personality changes. So they get irritable, they get paranoid, they start accusing people. I had money here where somebody stole my money. They start relating differently to people. So their behavior patterns change, so they may stop. So some difficult behavior, they may lose appetite, their sleeping patterns change, etc. So I think just these general changes, if we become a little more aware, and we know that this may signal a change, then we need to go talk to a doctor. It's better to go and find out that everything's okay. No need to worry, because if we catch it earlier, there are more options for treatment. There is no cure, but there are options for treatment, and also they can have a better quality of life going to someone like Hibiscus Place, and also for the carers and relatives and loved ones for dealing with them.
Right. So
The other thing that is helpful to have people be aware that it's important to get an early diagnosis is there's also the possibility that there might be pseudo-dementia, which is just depression, or a stressful situation. There might be a death, or there might have been something somewhat traumatic that can bring on kind of a delirium, confusion. If people can find out that someone is having depression, then that can be treated through drugs, therapy, and activities. Occupational therapists, we also work with people who are depressed to help them get back to the activities that they enjoy, that they may have lost through just general aging, the bad knees. I can't garden anymore, but then what's left? I'll just sit and watch TV. When gardening was important. So we can help modify homes, we can help tailor the activities, and work with possibly what might be depression to sort of rule that out.
Right.
And if there's still the changes in cognition, then we can say, well, then maybe we need to look further and make sure that it's what kind of dementia it is.
So diagnosis is critical.
Yes.
Yes.
Are our MDs, our doctors trained to look for dementia, and what are their referrals in terms of if they believe that somebody, given a particular age, is coming down with Alzheimer's? And does the association, for example, relate with the medical board and general practitioners?
We've tried on a number of fronts to at least give that much more education to Trinidad and Tobago. Remember, a lot of times, a lot of doctors aren't, studying in this field.
Right. Not specifically.
Not specifically,
age
exactly.
And,
and so, we are very young in Trinidad and Tobago in terms of having professionals who are studying those things. At least that is what we have noticed as an association. So I think we are in a very early learning stage in Trinidad and Tobago. And it's important that we keep, giving all these programs and keep having these things to educate, the general public so that if they see these signs, they could mention it to the medical professionals, and they can, say, yes, I believe this is so, but you still have to have it checked. I mean, memory loss, like Dr. Khadija said, is not Alzheimer's.
Right.
We all have memory loss.
Yes.
Yeah? And it's very important to have it checked. So, we rely heavily on, at least pointing out little warning signs to persons and let them at least have it checked by those professionals.
Right. Any idea, Khadija, in terms of research in Trinidad and Tobago as far as Alzheimer's go?
Yes, we do.
What do we have?
We do have an active body of researchers at UWI. There's a research team that has been doing work for a number of years in terms of the prevalence, trying to identify biomarkers, and those are to help diagnose dementia. But so there is that ongoing research. Some of the research I've been involved in, it's twofold. One, it's the cultural aspect. So in diagnosing something, it's only as good as the instrument you use. And if the instrument is not tailored for our population, then we run the risk of getting a wrong diagnosis. So I've been doing research for a number of years on trying to make the instruments we use more culturally valid.
Right.
This arose out of a consistent finding in the UK, that African Caribbeans in the UK were being diagnosed at a much higher rate with dementia than white British persons. So was it a case of there's just more dementia in African Caribbeans, or was there something with the instruments that they were using that was showing up that African Caribbeans were scoring lower? And I did find that. So I did find that culturally there are differences in how we perform on certain things in terms of memory, processing speed, attention. We have different cultural cognitive styles. So what we need to do is we need to find out what is our culture's cognitive style. So therefore, we can establish a benchmark for what is normal. And then using that benchmark now, we'll know what is abnormal.
Right.
So I think that's a critical thing in terms of refining diagnosis. So if somebody comes to you and they score poorly on a test, but this test is affected by education. Therefore, if you only went to school, if you only had primary school education, or if you have a university degree, then we know, intuitively, we know you're going to perform differently. But then we need to take it a step further and say, well, I need to take that into consideration. This person's background, this person's education, this person's functioning before they got ill. And then I can get an accurate diagnosis.
Right. Okay, we are at another break time. Please stay with us and come back after the break to continue the conversation on Alzheimer's. Welcome back to Psychology Live. The conversation revolves around dementia and specifically Alzheimer's, which affects some 50 to 70% of dementia, folks suffering from dementia. We have been talking about the need for early diagnosis, going to your GP. Maybe I could ask Khadija to just walk us through that diagnostic process in terms of if you're concerned about a family member, and you see certain signals that you all were talking about. It could be a one-time, as you were saying, Leslie, depression or a bout of depression does not necessarily signify that one is suffering from dementia and Alzheimer's, but how to discern that. So maybe you could just walk us through the process, and then I could talk to Alzheimer's Association in terms of what they offer to the general public.
Sure, sure. So diagnosis generally, if you are concerned or you have a loved one who's concerned, so you'd go to see your general practitioner, your regular doctor, and they will do some tests and perhaps do some screen and try to rule out other causes, if it could be something else. If they do have an idea that it's a dementia, ideally they would refer you to a specialist, and this specialist could be a neurologist, especially if it's a younger person, say younger than 60, so you could get referred to a neurologist. More commonly, however, to a psychiatrist, or also to an old age psychiatrist. We now have one in Trinidad, Dr. Bratt. This specialist then would undergo more investigations and examinations. So you will have a clinical interview where they get ask you more questions and also talk to your family members or your caregiver or your spouse or your relative to get some more information. They may also refer you to somebody like me, a neuropsychologist, to undergo some neuropsychological testing. And another important part is they may refer you to have a brain scan, so some form of imaging. So ideally for dementia, the best practice would be to get an MRI of the head. And the thing about the brain scan, so a lot of people are a little bit hesitant to get it, either because they have a little hesitation about going into this big machine, but also if it's done privately, it can be somewhat costly. If you do it publicly, then it may involve a bit of a wait.
Long wait, yeah.
However, I think it's really important because the most accurate diagnoses come from corroborating the information from the medical doctors and the neuropsychologists and the imaging findings. So all of the research has shown that if we use all of this, you can arrive at a more accurate diagnosis. Having received a diagnosis now, so let's say you've gone through all of that. And also, Keith, I'd like to point out, it's the going through all the steps is more important at the early stages when there are fewer clear signs. If you've progressed more into the disease, then you don't need as many investigations, it's more apparent. But especially for the early detection, we do need all of these steps. When you get the diagnosis, there is some treatment available for Alzheimer's disease, and these are cholinesterase inhibitors. So there are a few that are available on the market, and you can get them either as a tablet or a patch. However, this is not a cure, as we know. There is no cure.
For Alzheimer's,
and
right.
also, in terms of the treatment, you cannot reverse the process. What you can try to do is to slow it down. So there is that option. But most of the treatments and the intervention would be, and this is where we come to people like Leslie, in terms of managing the person's daily life. How then are they going to spend the rest of their years in the best way with the best quality of life possible? And I think it's really critical, and I'm really glad to hear that we have places like Hibiscus Place, and we have associations like the Alzheimer's Associations to help empower people with the tools they need to help both live with the disease, but also to care for other people with the disease.
Right. Let me remind you that you can call in. Our numbers are 675-8747 and 675-8749. We are taking calls for our guests. Lyndon, the association you mentioned, Alzheimer's Association, has certain activities. Could you just, well, tell the public generally?
Yeah. Right now, we run, well, it's like a caregiver information sessions. We run them the first Saturday of every month. It's at Nepal Street in St. James. The second Saturday of every month, it's at the Town Hall in Arima. And the last Saturday of the month, it's at the trying to remember, the Catholic Church in San Fernando.
Okay.
Yeah.
It's in the promenade?
Yeah.
Okay.
Yes.
Right. Yes.
I'm sorry, it just slipped me. And not having about Alzheimer's.
Yes.
Yeah. And we also have a session that runs in Tobago on the third Tuesday and or Thursday, depending on the demand. Right. So there we give information to members of the public about, what to expect when, if or when your loved one has the disease. And so it is really, like Dr. Khadija said, is to give the caregivers as well as, the family members some level of, I wouldn't say comfort, but to understand what, the patient will be going through.
Yeah.
And how best you can adjust your pattern, to help deal with the person with the disease.
Yeah. Leslie, in terms of your activities at Hibiscus Place, and generally you were talking about the family members. Well, we were all talking about family members because I find that the most challenging in terms of the adjustment that people have to make to take care of their loved one, and the understanding that this person that brought me up, right, can no longer, has all the faculties to really continue to take care of me. And I remember a cousin of mine who went through this a few years ago. His parents have passed away. But he was very knowledgeable because of his experiences. And of course, in Trinidad, we talk about, twice being a parent and then becoming a child again. And he made a comment that, you have to become the adult after a while and then decide, make choices and decisions that are best for your parent or the person that you're taking care of. And so the role reversal. Could you talk to me some more about that in terms of folks out there who are struggling to make adjustments as they see their parents, grandparents, elders, and some of the strategies and things that you experience at Hibiscus Place? Yeah.
Well, first, every family is different.
Yes.
So the dynamics in the family is always going to be different depending on the makeup and the resources that are available.
And the relationships.
And the relationships that have existed. So we often, usually there's one person who seems to take the responsibility and is responsible and has the demands and the challenges. that person is the person that we are likely to be interacting with. And often that person needs reassurance that they are doing great, that they're doing the best that they can, and they need to take care of themselves. Sometimes they just need to hear from a professional that what they're doing is good enough. It's unfortunately a progressive disease, so what you were doing last year is not going to be sufficient this year, depending on the advancement of the disease. But so families need to come to the understanding that they may get to a point where things are stable and the caregiver who comes in at night might be all that's needed, but they must think ahead. If physically the person is doing well, they will live, the brain will continue to change, and so they must think ahead for themselves and for the person, both at the same time. And just make those choices as soon as possible. If, for instance, we know that with Alzheimer's, there will be perceptual changes. There will be changes in balance. Then maybe the person's bedroom early on should come from upstairs and be moved downstairs.
Right.
Maybe the adjustments to the bathroom should be made. The lighting, the things in a house that could prevent falls and support the person in their declining perception, visual perception, spatial perception, so that they will be able to continue to be active in the home, because we want them to be active so that they keep up their physical skills and not have the falls that will then compound a person with falls and hip precautions, and a walker and crutches is at more risk than a person with just dementia but in physical good shape. So we as occupational therapists, we know the progression of the disease and we know the impact of the environment, physically, the physical environment, the social environment, on the person's ability to continue to engage in that environment in activities that enhance their quality of life. So that's our approach. So we're working to support the caregiver, but we're working also to help them navigate this journey with the knowledge of what is likely to come, what they can do now, so that they prepare for what's going to happen down the road.
Yeah. One, given our Trinidad culture, and I'm sure it isn't only confined to our culture, and I'm sure you've come across it all, where you have family situations where you have different opinions as to how to treat with this aged person or elder person, and you have conflicting approaches. Do you give advice on that? Do you counsel in terms of family counseling?
We do. That's part of what an occupational therapist does. OTs, occupational therapists, are trained. We're dual trained. We're trained in the psychology as well as the physical medicine, so we can do physical rehabilitation as well as the mental health interventions. But I would have to say that any professional today really appreciates working with the multidisciplinary team.
Right.
So while as an occupational therapist, my area of expertise is occupations and the environment, I still would turn to the psychologist, the psychiatrist, and the social worker. I want everybody on my team who has the experience and the skills working with the elderly population to give input.
Okay, let me just interrupt you just to take a call. Hello, caller. Good night.
Good night.
Yes, go ahead, please. You're calling from New York.
Yes, I am calling from New York.
Wonderful. Go ahead.
I just wanted to find out what was happening on a local level to help address the wandering situation with the people who have potentially been identified with Alzheimer's. Is there anything being done to educate them, the general citizenship, about how to deal with wandering?
Wandering. Okay, the sound isn't that clear. You want to know if there are any kinds of trainings in terms of helping people who are wandering as elders?
Anything being done to educate the caretakers?
The caregivers?
The caretakers.
The caretakers,
Yes.
in terms of wandering. Right.
Yes.
Anybody? Okay,
Well,
thank you.
That's a great question.
Yeah, I know. I actually
think
know of a family relative who used to be at, I won't call the name of the home, but used to be walking the street, would walk out to the home and be seen in town, and she was, 90s, 80s, 90s.
Yeah. Well, human beings are designed to be active,
Yeah.
and we're designed to engage in our environment. That's something that research has shown. So people who are wandering are doing what they naturally want
Right.
to do.
Yeah.
Because they have Alzheimer's, they will wander and forget where they've come from and how to get back. So an appropriate intervention from caregivers or in the adult day centers would be to allow them to wander, to walk around a safe environment, or to accompany them out into the community safely so that they can move. That's just a natural thing that humans need to do. So it's I think what we do is we would counsel and advise families
Yeah.
to provide an environment in which it's safe for that person to wander from room to room
Yeah.
or wander out in the yard. So again, making sure that the risk of falls
Right.
is low and encourage them. And then the other thing is the physical activity will help keep that wandering, the desire to engage in the physical activity channeled into exercises so that they're not just frustrated and wanting to walk
Right.
at night, for
Okay.
instance. If they're active in the day, then their sleep-wake cycle can be normalized, so they sleep at night, and they're less likely to be wandering at night.
Unfortunately, we've run out of time. Before we close off, though, can we just speak, Khadija, to
Yes.
prevention?
Yeah, so I think that's a concern many people have, especially as we're getting older. We want to
Right.
know, is there anything
stave off
we
or
can
prevent,
do?
yeah.
So there is nothing that you can do with 100% certainty. There is no way you can 100% avoid it, but there are many things you can do to help lessen your risk to some extent. In the list I gave you, Keith, one of the main ones for older people, it's socializing. It's
Yes.
having a social network, a healthy social network. One of the sad aspects of Alzheimer's disease is often when they get ill, that's the time they become more isolated. They lose a lot of their networks and their friends, and their range of activities becomes limited. So I think it's really important. So if they have the opportunity to go to a day center, to have friends around, to have family engagements, that's great. Other things in terms of which will help you with other things and also Alzheimer's disease, it's healthy eating, it's exercising at least 3 times a day for 30 minutes, it's watching the cholesterol, the blood pressure, managing the diabetes and the hypertension. These also help you with managing and preventing Alzheimer's disease. If you're a smoker, cut down. If not, quit. Smoking is also a risk for Alzheimer's disease. And just going back to keeping the brain active. So
Right.
it's like a muscle also. So keep it active. Try something challenging, do a crossword puzzle, do a debate, keep a diary, journal,
Yeah.
have conversations about things.
Yeah. Well, thank you. We've run out of time, unfortunately. I can see us doing a part 2. So I want to thank the Alzheimer's Association, Mr. Lyndon James, Hibiscus Place, Leslie Garcia, and Katisha Khan from the UWI for being our guest tonight to talk about this increasing disease as we have an aging population here in Trinidad. And the statistics tell us it will only get worse. Until next week, take care of yourself and those that you love. Bye-bye.
Thank you.